Emma. Emma.
Oh, Mbola bossa.
Oh, Mbola.
Can I
Okay.
hear?
All right, I'm on my phone. I'm just leaving work. Sorry, I'm a bit late. All right, go ahead. I can hear you guys.
Oh, shit. Thank you, boss. I'll just start first with this case.
Yeah.
This was a case prenatally diagnosed by ultrasound scan.
Okay.
Case is a newborn female, born via elective C-section last year, and the mom was 19 years old, a 19-year-old primate. So at birth, the neonate had a low EBGA score, so PEDS was there to help intubate and resuscitate the baby with fluids, after which the baby was brought to the OT room. As you can see in the pictures, like baby has a protrusion of the intestinal contents. There's no covering. Most likely it's coming from the right side. You can see large bowel, small bowel, and the stomach. And this was cecal atresia was noted. So in OT, after we noted the findings, resection and anastomosis of the cecal atresia was done. And then we made the size of the defect bigger, but we could not reduce the bowels back into the peritoneal cavity. So we placed the bowels in a silo bag. It's not really a silo bag, but that's what we could find at that time. And then we secured the silo bag underneath the fascia. So post-operatively, the patient was admitted to NICU, ventilated, sedated, started on inotropes and antibiotics. We monitored the urine output closely, and we did a daily reduction of the silo bag in the ward. On day 5, we noted that the patient developed a thrombocytopenia secondary to sepsis, so we stepped up the IV antibiotics, and then the patient was transfused also a unit of platelets. On day 7, a patient was taken for a delayed primary closure of the abdominal wall defect. So This is just a picture, like every day we would come in and we do a subsequent reduction. And this is when they finally managed to reduce the bowels back into the peritoneal cavity. Yeah. So I'll be talking on gastroschisis. The definition is a congenital anomaly characterized by defect in the anterior abdominal wall, through which the intestinal contents they freely protrude. Compared to an omphalocoele, there's no overlying sac. Usually the defect for gastroschisis is less than 4 centimeters, but for an omphalocoele, there can be a small omphalocoele where the defect is 4 centimeters and less, or a large omphalocoele, which is more than 4 to 5 centimeters. For the gastroschisis, the defect is usually at the junction of the umbilicus and the normal skin. Epidemiology for gastroschisis, overall prevalence is 4.3 cases per 100,000 live births. The incidence continues to increase for gastroschisis, whereas for omphalocoele it's 2.1 per 10,000 live births. For gastroschisis, it's more frequent in young mothers, young maternal age, those who are younger than 25 years old. In my case, it was a 19-year-old, and mothers who had a low or normal pre-pregnancy weight. 10% of these gastroschisis have some GI abnormalities like intestinal atresia. For an omphalocoele, it's more common in those with increased maternal age, more than 40 years old, and more likely to occur with overweight or obese mothers. Omphalocoele like has more association, has more link with associated anomalies compared to gastroschisis. So like for more associated with trisomy 13 or 18 or 21, or that back with Needham syndrome. Also, there's another syndrome, the Cantarell pathology syndrome. So embryology-wise, like for in week 6 to 10, the primary intestinal loop, like as the abdominal cavity is less because of the increasing liver size. So the primary intestinal loop, it will herniate throughout, where it will rotate to 70 degrees, and then it's supposed to return back by the 10th week. When it doesn't return back into the peritoneal cavity, that's when omphalocoele will occur. For gastroschisis, as you can see on the lateral folds, caudal folds, if it does not fuse where the yolk sac or the umbilical cord is, then a gastroschisis will occur. Also, there's like another theory that if there's disruption of the omphalomesenteric artery, it might cause ischemia, which might lead to abdominal wall weakness and then herniation. Also, if the omphalocoele ruptures, it'll be a gastroschisis. So clinical features, like I said, the gastroschisis usually most of the time is to the right of an intact umbilical cord. Its opening is like less than 4 to 5 centimeters, and there's no covering over the contents. So usually will sometimes contain intestinal loops or a stomach, as seen in my case, and the bowels are thickened, edematous, sometimes can be matted or discolored. And usually 10 to 15% have the associated anomalies. For omphalocoele, it's more central defect beneath the umbilical ring. So the defect, like I said, it can be small or large, and the sac is usually made of amnion or Watten's jelly and peritoneum. So the umbilical will insert into the sac. Usually with small femceles, you can have intestinal loops, but in the large ones, you can also have the liver, spleen, bladder, testes, and ovaries, which can come out and be with bowels. For investigations, like you can pick this up antenatally with a fetal anomaly scan. Also, like you can also pick up with increased maternal alpha fit protein, especially with gastroschisis, I think. Sorry, I just picked this out online, just a flowchart. So when for management of gastroschisis, when the first thing you do is to protect the bowel, and they usually cases require surgical, urgent surgical treatment. So before you go for surgery, they require vigorous fluid resuscitation. When the cases come to OT, you can either do a primary closure or a delayed primary closure, depending like if the intestines are too edematous or it cannot be reduced, then you can do a delayed primary closure. You can put it in a silo bag and secure it beneath the fascia, and then you do a gradual reduction until the edema settles. And while doing this, you have to monitor the airway pressures and urine output, just so that you don't cause increased intra-abdominal pressure. So you can do a delayed primary closure from 7 to 10 days. Some Schwartz is 1 to 2 weeks. And also you have to be careful, like when you put the silo bag, that it doesn't cause like a funnel as the intestine like is trying to return to the peritoneal cavity. I forgot to mention, like these cases with gastroschisis will also need like a long line and will require a TPN. For omphalocoele, compared to gastroschisis, like I said, because they're associated with a lot of anomalies. So they don't really require urgent surgical intervention like straight away. So with when the babies are born, you can attend to their vitals, maintain body temperature. You can also check their blood glucose, because with that, back with the Whitman syndrome, there's one of the features is hypoglycemia, so you can check that to rule that out. Make sure that you don't put pressure on the sac in case of rupture, or don't put pressure so that it interferes with the venous return. You can give prophylactic broad spectrum antibiotics just in case it might rupture. And you also have to assess for, like I said, anomalies, because most of the cases might have pulmonary insufficiency and cardiac anomalies. So you'll have to do an echo like that also.
Emma, is that the end of the presentation? Emma, is that the end of the presentation?
I think she's dropped out, boss.
Oh, yeah, okay. Give her a few minutes to come back on.
Yeah, sure.
Start thinking of questions.
Doc, I had a question.
Yeah.
In the case of cecal atresia, in this case, a primary resection anastomosis is better or pulling out a stoma, because it's a developmental problem.
Sorry.
Okay, hold on to that question. Let Emma finish.
Sure.
Sorry, I don't know why it dropped out. Yeah. Where was I? Right. Assessing, like I said, omphalocoeles are more associated with anomalies, so you have to check for the pulmonary insufficiency, and also for cardiac, you'll have to do an echo, and then you'll see if they're both cleared for surgery, and if the omphalocoele is small, then you can do a primary closure. Primary closure is can happen in cases of small omphalocoeles. You may require a layer of prosthetic material to help you close, to bring the fascia closer. But if repair is contraindicated in a omphalocoele, you can use topical ointments like sulfasalazine to you apply it over the covering, which allows it to harden, which might give it more protective covering. Reepithelialization will occur 2 to 3 months, which may lead to a ventral hernia. Yeah, I wonder if it'll ever be repaired with anomalies, but yeah. And these patients require an increased calorie support, high demand for healing. For long-term outcomes, omphalocoele, I just got this from online. The small omphalocoeles, they recover well. For large ones, they might have these associated problems after later, some gastroesophageal reflux, like I said, a pulmonary insufficiency, feeding difficulties, and failure to thrive. Gastroschisis generally do well, especially if it's just an isolated anomaly. They can have what's a short gut syndrome if you do a lot of if you do resection anastomosis, like sometimes you find that the gut has twisted on its blood supply and the bowel cannot be saved. So you do a big resection anastomosis, you will end up with a shortcut syndrome. I just did a short summary on equal atresia, intestinal atresia, because in my case, we saw this sickle atresia, as you can see in this photo, which I said like in 10% of cases, 10% of gastric cases, you might find it. So it's intestinal atresia is a broad term that describes birth defects that result in obstruction in the small or large bowel. So incidence of intestinal atresia can be 1 in 2,000 to 1 in 5,000 live births. So there's equal distribution in both genders. Intestinal atresia is most likely the result of a uterovascular accident, which is different compared to duodenal atresia. Is because the failure of recanalization, so you'll have atresia in the duodenum. So most commonly affected segment of the intestine is usually the jejunum followed by the ileum. Colonic atresia is comparatively rare. For intestinal atresia, neonates will present with signs of bowel obstruction. With ileum and jejunum, they'll have like bilious vomiting and abdominal distension. In the abdominal X-ray, you'll see proximal to the obstruction, you'll have air fluid levels. If you do a barium enema, it can help give the anatomic location of the lesion and can help you give you a definite diagnosis. So types of atresia. So you have type 1, there's a mucosal atresia with intact muscularis. There's a type 2 where the ends are connected by a fibrous band. In type 3, the two ends are separated by a V shape in the mesentery. And type 3B is like an apple peel or a Christmas tree deformity. Type 4, there's multiple atresias like a string of sausage or string of beads appearance. So that's just an X-ray I picked out. Just some deleted bowels, and this is a barium enema. So for intestinal atresia, surgical correction is usually needed urgently, especially when there's a possibility of a volvulus. So you can do a primary resection or anastomosis, or you can do a stage procedure. You can pull out a stoma and then let the baby stabilize, and then you can go back and then close it. Do anastomosis later when the patient is much better. Also, like omphalocoele, like you'll have to rule out the other anomalies which might be associated with multiple atresias. So like an omphalocoele also, the outcome is dependent all on the associated anomalies and the birth weight. And usually it has a good prognosis. So that's my presentation.
Okay, first question was from Michelle. With the ileocecal atresia, is it safe to do a primary anastomosis?
What I read was like you have to protect the bowels first. So you can just put the bowels in the silo bag, and then when you've reduced it, you can come back and then do resection.
Okay, so what are the indications of doing a primary anastomosis? So a good example is your case. If you look at the eviscerated bowel, there's not much peel. It doesn't look too edematous. It doesn't look too inflamed. It's viable and it looks healthy. So with your case, you might think of doing a primary resection and anastomosis. So Michelle, to answer your question, it's a decision that you have to make at the time of the first assessment. If the peel or if the bowels are so edematous, often what you see is just a cocoon of bowel loops. And you really can't tell whether there's an atresia or not. And you still try to close the abdomen primarily, and in 25%, you might have to do a silo, as in this case. And then you come back. So you allow the baby to grow. Even if you had missed an atresia, you can always do that at a later stage. The primary aim of the surgery is to close the abdomen, as what Emma was saying, to minimize or to reduce the ongoing fluid losses. So you've recognized it, you identified, you document it, and you return the bowel. But in this case, it looks like the bowel itself are quite healthy. There's not, it doesn't look too inflamed or too edematous, because there is a 10% leakage rate if you try and do resection and bowel anastomosis if the bowels are edematous. This one looks healthy.
Yes, boss.
Okay. Other questions?
Yes, Dr. Chitoko.
Yep.
Yeah. So how can we rule out any distal obstruction if we want to do resection and primary anastomosis?
Excellent. Very good question. Given that it's only 10% that have issues with malrotation, atresia, hypoplastic gallbladder. So in 90%, you know that the bowel would be patent distally. So I normally start off with a rectal tube or a Higa dilator to stimulate the anus and to empty the rectum as part of my closer. I always do an abdominal stretch as part of my closer. So if you're going to do bowel anastomosis and resection and not having excluded a distal obstruction, there's a risk which can contribute to your 10% leakage rate. By assumption, 90% of the time, there will be patent bowel distally. However, what you can do on the table is you do saline irrigation to make sure that the distal colon is patent, and you stick a thermometer into the anus and the rectum, and the anesthetist can check whether the temperature drops as you flush saline through.
Okay. Yeah.
But if you're not certain, if you're not happy, bring it out as a stoma.
Yes.
And it's the same principle when you have a bowel that is sticking out in your silo and it perforates. The same principle is, because you can't determine whether there is distal obstruction or not, it's probably best just to create a stoma.
Yes.
So for safety, you do stoma. You have to have good indications to actually do a primary anastomosis.
Yes.
Remember, there's no rush with these kids. You can always come back, as Emma was trying to describe. But if you do anastomosis and leaks, you'll potentially kill the baby.
Yes.
Okay. Questions? So for a question to Emma, the mode of delivery with antenatally diagnosed gastroschisis, what's the thinking nowadays? Because it comes back to your case as to why the lady had
What
a
I just
cesarean
read in
section.
Schwartz is this like yes. What I read is like there's nothing superior to elective C-section or a normal vaginal delivery. It's just both equal. What determines it is just like the gestational age of the fetus. Like
Okay.
it's more better if they're not premature, they do better.
Okay. So you want to allow the pregnancy to reach term, or at least 37 weeks? The in or delivery,
Yes.
or the mode of delivery, even though Schwartz is quite old, we would still recommend vaginal delivery. But the delivery has to be done
Yes,
in a
boss.
tertiary center. So rather than this baby being delivered in Korovo, if it was antenatally diagnosed closer to term, they would move closer to SUVA, so that it's delivered in a tertiary center where service like in your kid. But the actual mode of delivery is only determined by the obstetric indication. And I have not heard as to why this mother had, as to what was the obstetric indication for the cesarean section. So something to think about, right? They
Yes,
should not have. They should not have a
yes,
cesarean
boss.
section just because it's a gastroschisis. That's not an indication for C-section. Okay. The
Yes,
role
boss.
of antibiotics. You mentioned giving antibiotics. What's the indication? Anyone?
Prophylactic, boss.
Prophylaxis. Okay. So single dose rather than everyday doses. So I would have just given a single prophylactic dose at the time of surgery. And I would stop giving it unless if I'm putting on a silo. As you would know, with foreign bodies, the risk of infection, then there might be a therapeutic dose. So in your case, I would give a prophylactic dose. And if it's silo, then I would continue with therapeutic doses. And even then, they would still get the infection. So the
Yes.
earlier you reduce it, the earlier you take them back to theater, the better, rather than waiting for 1 or 2 weeks, as in Swartz. By 7 days, or in your case,
Yes, boss.
by 5 days, sepsis sets in. So the earlier you take them back, the better. Okay. And you mentioned, Emma, in terms of the fluid assessment to be aggressive. You don't need to be aggressive with fluid replacements. It has to be adequate replacements, which means you give fluid bolus, you measure the urine output, you reassess the hydration status, and you count also add the ongoing losses from the eviscerated abdomen. So that has to be included. So it doesn't have to be aggressive. It has to be adequate. If it's too aggressive, then the baby will become too edematous. So it should just be enough. And you have ongoing monitoring, ongoing
Yes, boss.
fluid bolusing if needed. Now, in your talk, you've combined gastroschisis together with omphalocoele. You could have just presented this case, which is gastroschisis, and stick to gastroschisis and don't confuse yourself. Unless if you are doing a presentations of 2 cases and separating the 2 differences, a gastroschisis, a case of gastroschisis and a case of omphalocoele. So then you present as a broad topic of the common abdominal wall defect in children. So I could have dealt with gastroschisis a little bit more. So I was waiting for the theory behind why gastroschisis develops on the right side of the umbilicus. Does anyone know that? Anyone know the theory behind the gastroschisis? Why is it developed? Why does it develop on the right side of the umbilicus and not on the left?
No.
No? Okay. It does happen on the left. We've reported a case report of it more than 10 years ago, which we had in Fiji, which was a rare variant of it. Majority of gastroschisis, 85 to 90% happens on the right side. And it's something to do with the omphalomesenteric artery. It's an artery that arises out of the abdominal aorta in fetus. And one of the theories that the abnormal involution of that right omphalomesenteric artery that causes the right-sided abdominal wall defect. The other theory is the umbilical vein, the abnormal involution of the umbilical omphalomesenteric vein. Now the right usually regresses at 20 weeks of gestation. There's a theory that says that it's something to do with the abnormal involution again of the vein that resulted in the gastroschisis. The ruptured sac, the theory of the ruptured sac in omphalocoele actually doesn't make sense. Because if you have a ruptured omphalocoele sac, then you'd expect the defect to be in the umbilicus, to be central. But it's not, it's more towards the right side. But that's another theory, eh? Resulting into the why the defect is only on the right side. And you've talked about the other associated anomalies. The good thing about gastroschisis, apart from the gastrointestinal tract, it's usually an isolated problem. Boys tend to have undescended testes. I just operated on previous gastroschisis of mine who's 18 months old today with a right-sided, actually bilateral undescended testes. The left one he presented with 6 months ago with torsion of an undescended testis and that was salvaged. And today we did the right side, which was also ectopic. So they can have undescended testes. They can have adhesions causing bowel obstructions. And the immediate postoperative period, they can also have necrotizing enterocolitis. So every time you go back to the ward and reassess this closed abdomen, always think of, especially in prem babies, which are the other associated condition with gastroschisis, they're prone to NEC. Yeah, so always think of NEC when you see them post-op, and if they're running into problems with not tolerating feeds, abdominal distension, and rectal bleeding, low platelets, think of NEC. And also think of line sepsis. As Emma was saying, you need a central line for your parental nutrition. Now, in Fiji, before parental nutrition, the survival rate was only 10%. And that had improved to 50% when we started thinking about nutrition. So we used to be quite aggressive with feeding our gastroschisis in Fiji without parental nutrition. We put an esogastric and just push feeds, even if they vomit. And we managed to increase the survival rate to 50%. With centers that have parental nutrition, survival is now 90, 95%. Hardly any deaths from gastroschisis. Whereas omphalocoele, as Emma was saying, because of the associated anomalies, they have multiple or other problems that contribute to their poor survival. Questions? Emma, what causes the pill or the inflammation of the eviscerated bowel in utero? Emma?
Exposure to the amniotic fluid.
Yeah, but
Sure.
if it's clean amniotic fluid, then it shouldn't be any inflammation at all, like your one. It's usually when the baby has pus meconium, eh?
Yes.
So for some reason, the baby has
Passing.
pus meconium in utero that contributes to the pill, or there's some sort of inflammation or amnionitis that causes the degree of inflammation of the bowel. Eh? But if you have clean amniotic fluids, you'll get a healthy looking bowel like your kid. And I suspect it's the atresia that must have resulted in that baby not pooing in utero, hence you didn't see any inflammation at all. So meconium in utero is bad for eviscerated bowel. Eh? Okay, any other questions? I didn't hear anything about the rotation of this eviscerated bowel, Emma. To me, it looks like there's malrotation.
Yes.
There was malrotation. Can't remember.
I think so, boss. Yeah, I can't remember, boss. I'm sorry.
Okay, because it looks like there is. Because you have what almost looks like a Christmas tree appearance of your eviscerated bowel loops. So I would have reassessed the location of the DJ flexor in relation to the rest of the eviscerated bowel to make sure that the mesentery is wide
Yes.
and the DJ is in normal position. Who was the surgeon looking after this baby?
Dr. Chasese and Dr. Low.
Oh, yeah,
I think
okay.
the whole team, boss. The whole team.
Oh, yeah, okay, okay. Okay, questions. Difference between a silo using saline bag versus pre-made silo makes no difference. Even in a developed country like New Zealand, I still would consider using a saline bag if I can't find a pre-made silo. The advantage of pre-made silo is you don't have to stitch it to the abdominal wall. Whereas with your saline bag, you have to stitch to get that seal. Otherwise, you get ongoing peritoneal fluids leakage around the bag. But as you've demonstrated, you can use anything just to cover the bowel for a few days while you try and squeeze it back. Yeah? Did you leave a nasogastric tube?
Yes.
Okay.
Yes, there was a NG tube, boss.
Okay. It looks like this kid was done really well. So it would have been discharged without any other long-term issues. But if the kid represents with bilious vomiting, abdominal distension, and pain, maybe we consider doing a contrast study to assess the small bowel rotation before you operate. Rather than just thinking of adhesions causing bowel obstructions, think about malrotation as well with volvulus. Okay. Questions?
Was just wanted to ask you, so
Yep.
for a case like this, if you said that return to theater should be at least in a week or at the maximum 2. So if the dynamization of the abdominal wall does not occur because of due to failure to thrive, what are other options that we continue
Use
with the
stuff.
transplant?
The trick is to get this baby within 5 days if you can. So be more aggressive when you push bowel. So you make sure that the kid is well sedated, ventilated. Part of the problems in Fiji is trying to squeeze bowel on a baby that is tubed, but not well sedated.
Right.
So you struggle to squeeze the bowel in and the baby would not tolerate it. But if the baby is well sedated, the bowel itself looks healthy in the bag, be a bit more aggressive. I do it twice a day. But your aim is to go back in. By the time you go in after 1 or more than a week, the abdominal wall itself would not be, you know how initially when the baby is born, the abdominal wall is soft, relaxed, it's not inflamed. After a week, it's difficult to close it. And the principle of closing would be, even if you just close the skin, majority of cases, like I've been closing the skin for more than 10 years. And I've had one kid who had an umbilical hernia. So I'm looking at that. I would just attempt to close the skin rather than trying to close the fascia.
Right.
Yep. The fascia itself will migrate across the incision or across the wound. But if you close the fascia and then close the skin, these are the kids that you might compromise the intra-abdominal compartment. And it's too risky. Just do a nice purse string around the skin, should come together, or do interrupted like with this one. You've extended the incision. I probably wouldn't, but since you've extended the incision, you close some of the fascia and then close the skin from your incision, and there are initial defect, you can just do a purse string. I use Vicryl 50 or 40. But the most important thing for these kids to survive is parental nutrition. If you don't have parental nutrition, all your hard work, as we've demonstrated in Fiji, is only 50% that will survive. Okay. Questions? If you have to choose between the defect, abdominal wall defect to have, is the gastroschisis rather than omphalocoele. Emma, for omphalocoele, the omphalocoele minor is the one that you can close primarily. Omphalocoele major, the risk associated with closing it primarily is too, I suppose it's actually too much that you can kill the child. So it's best to be treated conservatively and you do a delayed ventral abdominal wall hernia repair later, especially in your setting. So Save had done one, I think about 1 or 2 years ago, and he's very fortunate that the kid did well apart from wound infection of the skin. It can be done. Even in developed countries, there'll only be 1 or 2 people that would do it primarily. Majority would treat it conservatively. Part of the risk is you can cause intra-abdominal compartment syndrome, or you cause splinting of the diaphragm on a kid who already have some lung hypoplasia. Couple of years ago, one of my colleagues in Wellington did one who I had managed conservatively over the weekend, and the kid ended up having ECMO post-op. That's the degree of respiratory embarrassment that you can cause by closing the omphalocoele major. So safety, you shouldn't make any attempt of doing it primarily. Do a delayed abdominal ventral wall hernia repair later, after 2 years. Easy, and the baby would survive the respiratory issues. But minor ones, you can do that primarily.
Sorry, Benoit, just a question. I think 2 years back we were just starting to paint with betadine. Do you use like a different medium like Acticoat, or do you just use?
I treat it like burns. You know, I
Okay.
just treat it like burns. I use Acticoat 3 or Acticoat 7.
7. Okay.
And just use a crib bandage, and that often keeps the crib keeps the eviscerated bowel in the center. Even if the baby turns from side to side, I use crib over and around the baby. And it just epithelializes. It takes a couple of months. The issues with betadine, if you're using it on the sac, it can get absorbed. So you might have to monitor the thyroid function if you use betadine. I wouldn't use SSD, it's too moist.
Okay.
When we used to use SSD on burns, we used to have infection all the time. So I wouldn't use SSD, I would use the Acticoat. Or even if you just leave it alone, it will just dry up.
And your time to fix, do you usually fix them in about a year or so down the line, or how?
More than a
soon?
year, more than a year. Yeah, let the kid grow. So I've had 2 since I've been here. And I ended up just repairing the ventral wall hernia later when they're about 18 months old.
Okay.
As you said, gastroschisis is more prevalent than the omphalocoele. So we're seeing more gastroschisis here than omphalocoele. Okay, questions? Yep.
So just regarding this picture, I've seen you close the gastroschisis with purse string. Is there ever a time that it's too wide to close, that you just reduce the defect and put on another silo bag?
Excellent, good question. Hence why you shouldn't make the defect bigger.
Yes, yeah.
Okay, so the first thing is don't make it bigger if you don't need to. And most of the gastroschisis that you see, the defect is enough for you to do the laparotomy. It's the size You've seen me doing a laparotomy in these neonates. The incisions are small, and the defect, that's enough to do your laparotomy.
Yes, yeah.
So if you keep the original defect, then you should be able to close it in one go. Whereas looking at this photo, because they've extended the incision, so they should at least make an effort to close where they've extended. Close the fascia, close the skin, but coming closer to the umbilicus, the advantage of doing a purse string at the umbilicus, often when it heals, you just have a nice looking scar that looks like the umbilicus.
Yes, yeah.
With this one, you definitely have to do interrupted or subcuticular closure from the edge towards the, I think, the right side, when you're closing it towards the midline. But I personally would not have extended.
Yeah.
Emma, in your reading, you might have come across the gastroschisis that tend to close in utero. So these are the kids that would often have a short gut to start with. And when you actually examine the abdomen during or after delivery, there's no defect to be seen. That's a variant. So gastroschisis that dies off in utero and the abdomen will still continue to close, but they have a short gut and an associated atresia. And the thinking in terms of the timing of delivery, you would want to reach 37 or term. There is a hidden mortality associated with gastroschisis. Some of these babies would die in utero before they reach 35 weeks of gestation. A few years ago in Melbourne, they were doing a study looking at what could be done to identify these kids that die early in utero. And they didn't really come up with a definitive delivery. So the conclusion from the Melbourne study was towards 30 weeks of gestation and above, they should have a weekly ultrasound scan. And if there's any evidence of poor fetal movements or poor fetal heart, the baby should be delivered. So that would be an indication to do a cesarean section based on the fetus, not based on the gastroschisis. Otherwise, you allow the baby to reach term if there's no other issues in utero. So it's the crucial part is regular scan weekly from 30 weeks until delivery. Otherwise, you'll miss the hidden mortality cases that often die before 35 weeks.
Dr. Chitaka, sorry, just a question. Is there like would you apply a different approach if you had like a bladder extrophy, like when you have the bladder out, or would you still approach it similarly to what you do here, like for the normal gastroschisis? Would you?
So bladder extrophy is extremely rare, 1 in every 50 to 60,000 live births. And we've had 2 kids in Fiji that I could remember, an Indian boy in Singatoka, and there was a girl in Suva. And those are the 2 kids that I've remembered from medical student to when I was last there. Uncommon. So you might not see one during your surgical run in Fiji. And the treatment would be to make an attempt to close the bladder primarily. And that would include closing the abdomen. The epispadias part, someone else can come and do it. So it's not as straightforward as gastroschisis. Yeah. So the bladder extrophy, remember, it's the actual bladder that it's open up into the abdomen, and that might include the rectum or bowel, because you can have a cloacal anomaly associated with the bladder extrophy, so they are more complicated.
So you would still close it primarily like how you do gastroschisis, and then you fix the epispadias later, like later. Down the line. Okay.
Yeah. And in girls, you would still close the bladder acutely when you can, and someone else will come and reconstruct the urethra and the vagina, and might have to create a new anus as well.
Anyway,
Okay,
Sanjit, yeah.
questions? Yep.
Well, this is just diverting a bit on intestinal atresia.
Yep.
We just finished a case now, 2-day-old with bilious vomiting and no BO for past 2 days. And a gastrographin study showed there was this dilated loops of bowel with no free flow into the distal small bowels and in the large bowels. So we explored this kid.
Okay, so go back. So 2-day-old baby, delayed passage of meconium, and was the baby obstructed?
Yes.
Okay. And with the obstruction, meaning that the abdomen was distended, there was palpable or visible bowel loops.
Anyway, this baby was examined by one of my colleagues, and I just happened to go in theater.
Okay, so we don't know that part. And was there bile in the nasogastric tube, or did the baby had bilious vomiting?
Yes, bilious
Okay.
output in the NGT.
Okay.
And
So
there was
so the initial diagnosis would be a neonatal bowel obstruction.
Yes.
Okay. And delayed passage of meconium, I'd be thinking Hirschsprung's disease.
Okay, so there's no meconium that was passed.
Yeah, so I'd be thinking Hirschsprung's disease. So the first thing that I would do is I would take a ear swab, and I would stimulate the anus to see if there's any explosion of bowel motions. And if there's none, I put a rectal tube and do a gentle saline rectal wasage of 10 mils per kilogram. And if there's still no explosive, I might do a contrast enema, but I would do an upper GIT contrast to assess for malrotation first.
Okay.
And if there's no malrotation on the upper GIT contrast, then I'll do a contrast enema at the same time. So you see, I'm still thinking Hirschsprung's. And if it's not Hirschsprung's clinically, with anal stimulation, with the saline rectal washouts, then I have to exclude malrotation.
Okay.
Before I proceed with the laparotomy. So I would expect your findings to be dilated colon, dilated small bowel, and you didn't know what to do next.
Yes, Vinay. So this, as we entered the peritoneum, we noticed dilated duodenum and collapsed ileum, collapsed the entire large bowel. We've noted a type 1
atresia.
Jejunal atresia.
Okay, so that would have been classical on the X-ray. So your abdominal findings would suggest one single loop or upper abdominal distension. And if you go back and look at your X-rays, you would see that the stomach, the duodenum with jejunal loop that would be dilated. So you would have a classical X-ray features. So the reason why I would still have done a contrast enema preoperatively is that, as Salesi was saying, I would want to make sure that there's no other distal obstruction. And we'll demonstrate the microcolon before I do a laparotomy. Otherwise, you'll have to inject saline, warm saline from the top to see that it goes through the microcolon. But I demonstrate that preoperatively. So go back and have a look at the X-rays. It'd be a classical stomach bubble that extends to the duodenum. You see, upper abdominal distension with dilated bowel loops.
This is the case.
Yeah. So that's what I was saying. You can see the dilated bowel loops, and you would feel it as well. And you'll just see a distended stomach, duodenum, and a loop of jejunum. This is just a classical jejunal atresia. It's
And
good.
yeah, anyway, the thing is, the jejunum was massively distended, dilated.
Yep.
And the ileum was collapsed.
Unused. Yeah, it was unused.
The discrepancy would have been more than 10. And so we
resected.
Yes, we called in Dr. Chasese, who came and did a resection, and we did the end-to-side anastomosis.
Okay.
And is there anything that we would have done differently for this kid, apart from the preoperative?
So where exactly in the jejunum? How far is it from the DJ flexor?
It was approximately 20 to 30 centimeters.
Okay. So if you bring out a stoma, it will be high stoma losses. And the advantage of bringing out a stoma is you want the proximal bowel to reduce in caliber, so that when you go back, at least you get some degree of bowel ends that you can do a good end-to-end anastomosis. But the problem here is that you'll have high stoma losses. So I would agree with resecting. But when you resect all the dilated bulbous part of the bowel, and you can take 10 or 15 centimeters. But make sure that you measure the length of that unused ileum, so that you have good length of bowel, because you don't want to end up with short gut. And the dilated bulbous, take it as much as you can, so that you can have a discrepancy of 1:5, 1:6. And you do an end-to-end anastomosis rather than an end-to-side. Physiologically, peristalsis works better from bowel end to bowel end. Side to side is an adult type of anastomosis, and they often have to be wide. And you can't do that with small bowel, especially neonatal bowel. So I would suggest doing an end-to-end anastomosis, but you resect. And you might have to do a tapering resection. Do you know what I mean by tapering resection?
Is it teeth slits that we do on the anti-mesenteric border?
You actually resect and then do have you seen a dilated ureter being reimplanted? You actually cut the anti-mesenteric part end of the bowel, close it, and then do an end-to-end anastomosis.
Sorry, boss, I'm just showing the pictures they've sent to me.
Yeah, so the X-ray, that's jejunal atresia. Yeah, so that's just jejunal atresia. So you seeing the stomach? Now it looks like this kid had a contrast.
Yes, was given gastrographin.
Yeah, I probably wouldn't, because air is a good contrast, and you would have seen that stomach, which extends to the duodenum, and then that single loop of jejunum and stop. So if you have a original plain film without the contrast, any other apart from this one? So this one is just demonstrating the stomach and the paucity of bowel shadows within the rest of the peritoneal cavity. So you'd be thinking high obstruction. So I would wait for a few hours, allow gas to go in, and repeat the X-ray. This is with contrast. So if you go back to the plain films before the contrast, yeah, there should be probably another one after this. And I'm sure that you would see just a stomach duodenum and a loop of jejunum. So depending on where the bulbous or the length of the small bowel, if I have to, I'll do a tapering resection and then still do an end-to-end anastomosis. The end to side would not work very well. I mean, physiologically, the two ends are not joined together properly. So don't be surprised if you have to take this kid back to theater for real laparotomy.
Dr. Chitoko, can you just re-explain what you mean by the tapering
resection?
resection?
I
still don't get it.
So the bulbous end on the proximal side, it's too big to do an end. The discrepancy is too big. So you can make the end smaller by actually cutting the anti-mesenteric side.
Anti-mesenteric side. Okay.
You cut part of it and then close it.
Okay.
And as you close, it narrows the opening on the proximal end. So at least you can do a 1:5, 1:6 discrepancy of end-to-end anastomosis. But the problem is you now have two corners that you're going to be cautious about, the two edges on the anti-mesenteric side of the tapering bowel, because that's where it will leak. But if you do a good anastomosis, it shouldn't leak.
I will still call this a end-to-end anastomosis, or?
Yes, it's a tapering resection with end-to-end anastomosis. So your effluent travels freely from proximal to distal. Otherwise, you'll have turbulence of flow from the proximal dilated to the side of the distal ileum.
Thank you, sir.
Okay. Any other questions?
Sorry, Vinay, just going back on the omphalocoele and the gastroschisis, because most parents come in and ask us if there's any modification of sports or anything that they're restricted to, especially for those kids who have like omphalocoele major.
Yeah.
Would you recommend like activity modifications when they're undergoing this treatment, especially those who are more vulnerable to trauma, or should they avoid contact sport? Because it's one of the
once you repair, you wait for the repair to heal, and those kids should be left alone to do whatever they wish. If you're worried about the integrity of your repair, then you'll be concerned by restricting them from playing sports, which doesn't make sense. If you've done a good repair, you've allowed the wound to heal, and if there's no recurrence from when you follow them up, or at least the first follow-up, just let them be. Let them be kids.
All right. Thank you very much.
Okay. Any other questions before we call it a night? Emma? Yeah, so you see the discrepancy between the proximal bulbous end and the distal unused bowel. That is it that the anastomosis is being done?
Yes, Vinay.
Yeah. So you look at the bulbous end, the viori behind the atresia, it compromises the blood supply of that bulbous end. So even if you've done the anastomosis like this, it doesn't work very well. So you might have to go back and resect the bulbous end. There is always aperistolysis or poor peristalsis at the bulbous end. So you should have resected it.
And you resect it till it goes back to like a non-dilated segment or less
Yeah,
dilated
and often it takes about 10. The longest I've removed is 15 centimeters. To some smaller caliber, because it's usually known as dilated proximally. So I'll take it further up. So the bit that whoever is holding the bowel on the anti-mesenteric, that's the bit that you excise. So if you cut across and the index finger, if you cut all that off and then close it, then you end up with a smaller opening on the end, on the proximal end, and then you do an end-to-end anastomosis. Tell Save, I'll ask Save to show you how to do a tapering resection. Because if you leave the bulbous end so dilated like that, that's where you'll have stasis of effluent. And that's where it will get reobstructed. So let me know when you've reoperated on the kid.
We hope not. Another thing.
Yep.
When should we initiate feeding for this kid?
Okay. You don't have TPN, so the sooner the better. You would look at the abdomen, you would make sure that it's soft. And you look at the nasogastric losses. If it's less than 1 mil per kilogram per hour, start introducing feeds. Because the sooner you start stimulating the gastrointestinal tract, the better. And that can be with trophic feeds of 1 to 2 mils every 2 to 3 hours. And as the volume increase and as the baby tolerates, then you keep increasing. And the sooner these babies will die in your setting because of sepsis related to poor nutrition. Whereas here, these babies would be on parental nutrition for months while we try and establish the enteral feeds. In your setting, nasogastric, start feeding early, which means once you're happy with your anastomosis, which means in 48 hours, you should be thinking, I should start feeding and trickling 1 or 2 mils of milk every 2 to 3 hours. But you'll be guided by the abdomen, you'll be guided by the nasogastric losses.
Thank you. Thank you, sir.
Okay.
Sorry, Vinay, just another question. Would you consider continuing antibiotic coverage for longer than the prophylactic period or for these types of anastomosis or no?
Not for this atresis,
Not
no.
for these atresis.
1 dose in theater is enough.
Thank you.
The difference between a silo is you might have to give therapeutic dose because of the foreign bodies being used on the abdominal wall. Whereas in a atresia like this, now a single dose in theater is enough. Okay, any other questions before we call it a night? You guys are doing interesting cases, eh? Okay. All right, call it a night then.
Thank you very much.
Nakaboso.
Yo,
Thank you.
Pinaka.
Thank you, sir.
Yep.